Yeah, it's already 9 a.m., but right now we have just 6 participants. Dr. Bature, should we wait a few more minutes or should we just go ahead and start?
Hello?
Yeah, good morning.
Yeah, morning.
Yeah, I said we have just 6 parts. Okay, now we have 7 participants. Should we wait a few minutes for more to join or should we just start?
I think we should start. I'm trying to send a reminder to the Telegram group.
Okay. Thank you very much. Okay, so good morning, everyone. This morning we have Dr. Ramsay-Hunt Nwachukwu, a senior registrar from the University of Abuja Teaching Hospital, Bagwalada. He's going to give us a case presentation on Bell's palsy. Dr. Nwachukwu, we are honored to have you here this morning, and thank you for taking this presentation. So everyone, if you have questions or comments, you can type them in the chat while the presentations are in the chat box while the presentation is ongoing, or you can wait to the end of the session to ask your questions or make your comments. Thank you very much. Dr. Nwachukwu, over to you.
Okay, good morning, everybody. Thank you for the opportunity to present here. Thank you for the introduction. So I just want to start with this slide. So just a question that, did you know, maybe you know, but it's something to remember, that the facial nerve closes your eye, makes loud noise tolerable, helps you with facial expression, helps you taste, spy, and salivate, makes you cry, and also innervates all the glands in the head, except the one it passes through. Very interesting nerve. So this nerve, I think to remember it, there's a scenario I wanted us to just paint briefly. It's probably called the lover's nerve. So imagine you take your significant other to a restaurant and you want to give her a surprise, or him or her. You cover their eyes and you ask them, maybe you have a cake or something, you want to give them a brand new car. So you cover their eyes, you ask them to close their eyes and not to open it. They unveil the gift, maybe there's somebody, a saxophonist, playing very beautiful songs so that they can hear the song. And you look at their facial expression and they're smiling with happiness, and around there's a cake for them to taste and salivate. And you see the significant other crying. After that, they eat the cake with a lot of salivation and munching, and they're happy. So just imagine all that is done by the facial nerve, okay? Now, this acronym has been there for a long time to Zanzibar by motor car. I don't know if we know about it, but it's something that will come up much later. So let's talk about the anatomy of the cranial nerve 7. I mean, it's a very interesting nerve. I will very summarize its function. And we may not be able to trace the cause, but just know that there are different parts of the nerve, and there's one nerve that does almost everything. It has both motor, general motor, and special motor. It has sensory, general sensory and special sensory, and it has autonomic. So it's a very good nerve. Okay, so this is a facial nerve proper to Zanzibar bimotor car, TZBMC, temporal zygomatic buccal mandibular cervical. Okay, modus of facial expression, the caudal tympani nerve anterior to the third of the tongue, carries special sensory taste all the way back to the brainstem, and the nerve that supplies all the glands apart from the one it passes through, because interestingly, the nerve that passes through the parotid gland is a motor nerve, but the specialized visceral, which is secretory, doesn't pass through the nerve. So it makes sense that probably that's why it's not supplying the nerve it passes through. So it's a question sometimes in MCQ. So the motor part passes through the parotid but doesn't supply it, but the other parts, So just briefly, arises from the pons, it transverses, in the pons, it also makes a very important bend around the 6th nucleus, forms a bulge in the floor of the 4th ventricle called the facial colliculus. Sometimes 4th ventricular tumors can cause central cranial nerve pulses because of that bend. So when there's something compressing the 4th ventricle, the floor of the 4th ventricle, the nerve hacks around the 6th and forms a bulge in the floor. So sometimes there's erosion or pressure, you can have a facial nerve pulse. So it transverses and leaves the brain because it's a cranial nerve and it's from the head and goes out through an orifice. Most of the cranial nerves have that function or have that peculiarity, except the optic nerve. So it transverses the internal acoustic meatus in temporal bone and gives rise to 3 branches. Okay, the facial nerve proper supplies, because it's from the branchial arc by origin. So it's also called the brachiomotor nerve. Okay, yeah, so to the facial muscles, the caudal tympani, and we've all talked about this. So here's the case, very interesting case. So 58-year-old gentleman, otherwise healthy. Right facial droop 3 days prior to presentation. Was apparently well until about 3 days prior to presentation when he woke up and noticed right facial droop. He also noticed that he could not close his right eye properly, but has not noticed reduced tearing. Maybe he didn't see any tearing problem in that eye. So there was secretion. Remember, the cranial makes it cry. Okay, so he didn't notice that, but he noticed that there was redness, unnecessary tearing and grittiness. So what I wanted us to do here is to pay attention to the pattern. For cranial nerves, it's always good to, first of all, clock the symptom, then clock the presence of other cranial nerve abnormalities, and also try and put in the questions as you go to identify what part of the cranial nerve are involved. So this tearing part, we've talked about already. So we're here is a clacking of the cranial nerve. So there's no change in his vision, no pain on eye movement. So we're cranial nerve 2 is normal, no double vision, no facial numbness, tingling sensation of the cheek or mouth. 5, no vesicles in the ear, complication of cranial nerve 7, we'll see later. No pain in front or back of the ear, so cranial nerve 8, no difficulty in hearing, intolerance to loud noise or hyperacusis, and no problem with balance. No dryness of the mouth. Remember, it supplies all the glands of the head and neck, except the one that passes through. And no problems with taste, caudal tympani, chewing or swallowing. Glossopharyngeal, maybe vagus a little bit. So no weakness on any part of his body or speech articulation problems. Then the causes are now being clocked. Possible causes, no fever, neck pain or stiffness, no history of previous head trauma, transient ischemic attacks or strokes. He sought care with his GP and was asked to tape his eyelids at night and use eye drops. His GP didn't place him on steroids, which is standard practice. From NICE guidelines, should have been giving some steroids, but he wasn't. But they thought he had a stroke actually. So they admitted him via A&E, had a head scan and CT scan, which was normal. This standard practice in the UK because they feel like if a person comes with that kind of droop, they feel like it's a stroke, they send him to the A&E to have a CT scan done immediately. So at that point, the GP probably wasn't thinking of Bell's palsy. So he had a head scan and had an examination by the A&E doctor and was discharged from A&E, but he was asked to go and see his ENT because at this point with a normal head scan, they're already thinking he had a 7th cranial nerve palsy, maybe I just need to see an ENT. So the first person that they sent is to ENT because ENT treats cranial nerve palsies here. That's the standard practice. And when he was sent to the ENT was now happy and sent to neuro-ophthalmology. So I saw in neuro-ophthalmology, then no trauma to either eye surgeries and doesn't use spectacles. So it's not a known, so this Shade used to be the code in Nigeria when like everybody says sickle cell, hypertension, asthma, diabetes, and epilepsy. So I just try to modify it something like may suit everybody. So I put this C, but the S is not here, it's not here. So any cancer, so anybody that has a cranial nerve palsy, you should always ask for history of cancers in the past, breast lumps, prostate problems in a man. It's always good to ask because they may be there, you may not find out. And I'll tell you why after the discussion. Hypertension, hypo or hyperthyroidism, autoimmune disease, diabetes, endocrine abnormalities. So it's important to ask all these questions. They're very important questions because you want to see what can be causing. Because before you say something is idiopathic, you want to find out that you've ruled out all the possible things that can cause it. Until you do that, you cannot say it's idiopathic. So that's why they send to the ENT to check the ear and send to the eye to check the eye before they call it Bell's palsy. They'll just be saying possible Bell's until both people have seen. There's no family history of blinding, eye disease, or cancers, but nephew passed away 1 month ago with stroke. He's a smoker for 26 years, smokes 1 to 2 sticks per year, but doesn't drink alcohol, eats healthy, and not. This is another part of the history is very important in ophthalmology, especially in neuro-ophthalmology. What diet? The dietary history is very important. The social history, whether the person eats healthy. Some people eat very funny, and they have a lot of neuropathies just from their diet. So it's important to ask. But so he's not even diabetic too. He has no allergies, but he's presently on the eye drops that his GP prescribed for his problem with his eye. Examination, he wasn't pale, anicteric, or diagnosed. General examination was normal. Visual acuity was 6/5 in both eyes. Interestingly, his color plates were full. So also in the examination, pay attention to how the clacking is done with all the cranial nerves, 2, 3, 4, 5 in that order, and CNS exam. Okay. So that's what we start. So in cranial nerve examination, or anybody that has cranial nerve palsy, you start with the one that is number 2, then you check 3, 4, and 6 in the motility, then you go on and check 5 and 6 and 7 as the case may be. So here, visual acuity is 6/5, color vision is 17/17. So he has full field. So he has normal visual function. So we're sure that the optic nerve is fine. When we do visual acuity, color vision, and he has full field of comfort. So these are the examination findings grossly to examine the optic nerve in both eyes. Then you check the leads. The leads is very important. I can give you the lead position, cranial nerve 3 or Horner syndrome. So it's good to say you comment on the lead. It's lagophthalmos with good Bell's phenomenon on the right and normal lead position on the left, so that they can know you checked for normal lead position. Then the orbital signs, if there's any problem in the orbit, no proptosis, so when they say normal ocular motility, you've already said that 3, 4, and 6 are fine. Yeah, quiet conjunctiva and sclera in both eyes. So the corneal reflex should be checked in every patient who has 7 cranial nerve pulse, because 6, as I said, the 7 cranial nerve at its origin in the brainstem. The nucleus is very close to the 6th, and also the fascicle, as it comes out, it takes a backward course, then curves around the 6th nucleus, forming the facial colliculus before it exits the brainstem at the pontomedullary junction. So you should always check for 5 and 6 and all that, because they're all related. Because as they exit, this one is 6 actually, the gen is 6. But they're all related at the brainstem, because they're all brainstem. And there's a very somehow gross way to know where the nerves originate from. So you have the brainstem, midbrain, pons, and medulla. So roughly 4 nerves exit from the midbrain, 4 from the pons, and 4 from the midbrain, 4 from the midbrain, 4 from the pons, 4 from the medulla. So something like that. There are 12 cranial nerves, so it's just a rough guide. But 5, 6, 7, 8 are very close, very close. So you always go to check them. So he had intercorneal reflex in the right, punctate epithelial erosions in the right cornea, tear film instability, possible due to dryness. Quiet anterior chamber, both eyes. He had no RAPD. Normally, in a neuro-ophthalmology clinic, they put this RAPD in this ocular exam up. But because in Nigeria we do AC before pupil, I just put it here. But here, they just do 6/5 color vision, full field, no RAPD. So they have finished examining the second nerve. They now move to that is. But I put it here for like make it complete somehow. ALS opacity, both eyes, normal findings on fundoscopy. CNS exam is very important. Any cranial nerve pathology, you have to do a CNS exam. Well oriented in time, person, and place. No neck stiffness. Intact sensation V1 to 3 on both sides. So you can see that, you were examining the cranial nerves that we couldn't examine here, and some things that we couldn't say in the ocular exam, we just brought them here to examine the remaining cranial nerves. But you should be seen to examine 5, 7, let's say the person had other cranial nerves. So you had intact sensation in a V1 and V2 and V3 distribution on both sides of the face. On cranial nerve 7 examination, you had absent forehead crease on up gaze on the right, weak orbicularis muzzle. So that means when you ask him to try to close his eyes, it's easy to open it on the right, but it was normal on the left. All other facial nerves. So you had weakness on all other facial nerves on the right side. So you had the facial droop, and he couldn't blow his mouth, and when he showed his teeth, there was deviation. So all of the cranial nerves were intact, like the 7 on the other side, and other cranial nerves. Systemic examination was not contributory. Bell's phenomenon, Bell's palsy with good Bell's phenomenon, right? Experimental keratopathy was diagnosed, even though he had mild cataracts. So because he had very good prognosis, and his age was fine, he's not up to 60 years. The ENT had seen him and he was fine, and he had good Bell's phenomenon, and he was already recovering. So he didn't have much exposure. So the only thing at that time to do for him was cancel him and give him to ask him more eye drops and tape his eyelids at night and see him in 3 months. So this is the reason why. Can I mute people?
I'm sorry, please, can we mute our mics? Please, thank you. Sorry.
Okay, so yeah, so now, when Dr. Nerat approached me to give this talk, I just felt that this was one of the cases that made me feel like I was stupid when I went to do a fellowship, and I just went. So it's cranial nerve 7, it's a very funny nerve. You ask questions about it, and it looks like, it looks like very simple, but it's not a very easy case to manage. So the first question, I just had to summarize the approach to all cranial nerves so that management-wise, we can have a good idea of what questions to ask. Now, this may not be complete, but at least I tried to put all the things in one slide. So is it the first episode? So every cranial nerve, most of them, they have recurrent disease, optic neuritis for the eye, microvascular pathology for 3, 4, and 6, which can be pupil evolving, not pupil. They all have recurrence somehow. They may not be, but at least, but the recurrence in the 7th is the other way around. So if you have recurrent in 3rd, you might think it's benign, right? Because microvascular, the person is going to recover and all that. But recurrence in 7th is problematic. Because if the person has repeated 7th, then you have to find something causing it. So that's why I put, is it the first episode? It's important because all the cranial nerves have some recurrence. So optic neuritis, if the person has it, the first episode is very good, the person recovers, and it's typical, person is not likely to get it. But atypical, you have to be careful and all that. The cranial nerve 3 and 4 and 6, microvascular or pupil evolving and all that. So the first question is it the first episode? So yeah, this man's one was the first episode. So it's good prognosis because it's 7th cranial nerve, first episode. But for other cranial nerves, it may not be the same. All right. So now, is it an isolated cranial nerve palsy? So it's important. Imagine, so let's say 50 years ago when there was no MRI, we needed very astute physicians to determine, the location of a lesion and how to manage them. Now we can do very complex imaging and find out a lot of things. But in places like Nigeria, where we don't have access to all those things, it's important to be able to identify cranial nerve palsies if they're isolated or not. And as we just said now, if cranial nerve is isolated, we can tell, of course, which side it is, follows suit. We can actually identify where the pathology is. So any cranial nerve, cranial nerve 3, you want to check if it's isolated because 3, 4, and 6 are in cavernosus sinus, right? 3, 4, and 6 are in the orbital apex. So you want to ask yourself, this third nerve palsy, is it in the orbital apex or in the cavernosus sinus? The difference is very massive, especially where you pay for different part of it. Let me tell you why. If it is cavernosus sinus or caused by aneurysm, you need to do MRA, right? To be sure it's not an aneurysm and not MRI per se, even though you still do an MRI. Then you need to also do MRI of the cavernosus sinus because that's where the pathology might be if it's 3, 4, and 6 is there. But if 2 is there, you see 2, 3, 4, and 6, then it is, it may be up to apex. And what you do in that case, you're requesting for MRI orbits, not necessarily MRI brain, or MRA. So you can see that just by knowing if it's isolated can help you know what to image for. Just clinical examination. And the only thing you can do is to check in torsion at the exit lamp for third cranial nerve palsy, but not for this case. I'm just saying for all cranial nerve palsy. So it's very key. Just that clinical bit of knowing if it's isolated can help you know where to image. On which side is it? So it's important because upper motor neuron lesions can cause contralateral problems. So you want to know, which side. Now, can you identify the site anatomically based on your clinical examination, or do you need imaging to do that? It's all the same, because if you see the features for the 7th cranial nerve, you can see, because it has different branches at different parts in its cause, you can actually tell where the lesion is. So for example, if the person doesn't have a 6th nerve palsy, that is not likely to be in the brainstem because the closest relationship between the 7th and the 6th is in the brainstem. So now, if the person doesn't have hyperacusis, the problem is after it gave off his branch, the stapedius muscle in the middle ear. So it's not likely to be an ear problem, so you can just trace the cause. If the taste is involved, it's before the origin of the caudal tympani. If it's after, then the taste will be preserved. If the tearing is there, it's after the greater petrosal. So it's good to know at what site and what the cause of the 7th cranial nerve and what it gives off. So you can tell where the problem is. So if the person still has intact posterior auricular sensation, then it's going to be after the nerve exits the stylomastoid foramen, because it was at the junction of exiting the skull through the stylomastoid foramen that it gives out the posterior auricular branches supplying the back of the ear. So if you have the back of the ear in sensation preserved, then you know that the problem has to be a parotitis. And this patient had all that preserved. When I examined him, he had intersensation behind the ear. So we just need that it's likely to be a lower motor neuron lesion, something in the parathyroid gland, maybe a viral parotitis or something there. So the anatomy of the nerve is very important. So, and by identifying the anatomy, you can actually determine the potential cause. And just for this 7th cranial nerve and other cranial nerves, because if you identify the anatomy, you can tell if it's an orbital apex, syndrome, or is the cavernosus sinus a problem, or it is posterior communicating artery aneurysm for the cranial nerve 3. But here, we can obviously tell that the person had probably a viral infection or something, or no known cause, something happened in the parathyroid inflammation and knocked out his 7th cranial nerve. and causing facial weakness because every other thing was normal. He could taste, he wasn't crying. He didn't have reduced hearing, and all that. So are there complications arising from it? All cranial nerves, when they have a palsy, there's a complication. So you have to identify how bad is this lesion. Is it complicated? Is it likely to involve other specialties? So for example, in seventh cranial nerve, the extent of the superior keratopathy, especially came 3 days. So he didn't have much complications. But let's say he came very late, he had a superior keratopathy and bacterial keratitis, and you're already having problems. You have to involve the cornea specialist because he may need tarsography, he may need to have patching with amniotic membrane, or he may need to have a corneal transplant. So you just to check what the complications arose from the cranial nerve palsy. It will also tell you what the prognosis is. For this seventh cranial nerve, I'll list the prognostic features much later so you can see what's important. And this last part doesn't really pertain to us in our practice in Nigeria, but in the UK, they have what they call multidisciplinary team approach. And in the multidisciplinary team approach, it's consisted of a lot of specialties. It's a compulsory management plan for anybody who has complex or not really complex, that has a cranial nerve palsy. You want to discuss with other people to be sure you're not missing anything because you don't want to have medical legal problems. So they always have MDTs, Tuesdays, Wednesdays, Thursdays, where, for example, Tuesdays, pituitary MDT, where all the pituitary adenomas, tumors, craniopharyngiomas, skull-based tumor, everything. Then they have neuro MDT, neurologists, neurosurgery, they come together every Wednesday mornings, all the cases for that week. They look at it one by one. What did they do right? What did they do right? And they now have ophthalmology MDT for ophthalmology. So they're very interesting, but that one is not important to us. But these are the things that we should know. So let's talk about Bell's palsy briefly so that we'll not spend much of our time. It's a facial weakness, and we've already talked about it. It's a diagnosis of exclusion. So hence, all the possible causes have to be excluded. You cannot make that diagnosis for the first time you see them. It's not advisable to do that. So it's mainly poorly understood. People think it's a virus, and these are the viruses that have been implicated. There are various severities, and it's important that I just put this here because of completeness. So they have inability to close their eyes. They have poor tolerance to loud noise, metallic taste, reduced lacrimation. So it's important to discriminate between lower motor and upper motor. We've already talked about that. Upper space, upper, that's another acronym or something in here. So the upper motor. So if you have an upper motor neuron lesion, these will be on the contralateral side, but the weakness will be on this other side, and it will spare the upper part. So when they try to look up, the skin crease will be preserved. Well, you can see this man had absent skin crease looking up, so it definitely has to be a lower motor neuron lesion. So there's this grading. I don't know if many of us know it, but it's important to just put it here for completeness. House-Brackman classification. They're easy to determine when the GP should refer to the ophthalmologist. And it's also used to assess recovery. So it's grade 1 to 6, normal function, mild dysfunction, moderate dysfunction, moderately severe, severe, and complete paralysis. It involves the muscles of the face mainly and how they were affected. If all the Zanzibar by motor car is affected, you will see just from assessment what. So upper motor neuron lesions, you have to think about the stroke, in the brainstem. It's a very common thing, subdural hematoma or brain tumor, because it can happen, anything can compress it at the origin, right? Then the lower part, remember, it's caused in the ear, middle ear, otitis media, cholestoma. All these things can happen. So it's a very interesting cause: brainstem, interacoustic meatus, middle ear, stylomastoid, foramen, and out parotid gland. So anything in the cause can affect it. It can be brainstem, it can be in the ear. So there are landmarks where you should look for things, and that's why ENT is always the first person to review seven cranial nerve pulses. So the management is probably to reassure them they recover spontaneously. Eye care is one of the most important aspects. You give them drops and patch, but the idea is don't always think it's isolated. And if it's the first episode, it's fine. If it's recurrent, you have to do full body imaging to look for what's causing it. So our patients presenting within 72 hours should be started on steroids. That's a nice guidelines. So when you diagnose it and you're sure you have everything to diagnose and you're sure it's Bell's, start them with steroids. From their nice guidelines, 25 milligrams twice daily for 10 days. Then giving 60 milligrams for 5 days, followed by anyone you want is fine. People say antiviral, but it's controversial. So a lot of controversies. So referral to ENT, we've already mentioned that surgical options are available if they have persistent weakness. Synkinesis could be treated with Botox. Referral to ophthalmology based on if they have Hauss-Brackmann grade 4 or more. So complications of it's 5% of the person recover. So these are the factors that cause poor prognosis. And see what our patient didn't have any of them. That's why we felt he needed only eye drops. So he had a complete palsy, but he was already recovering. He had no sign. He had signs of recovery within 3 weeks, so it was already a good sign. He was less than 60. He didn't really have pain. He didn't have any vesicles in his ear. He didn't have hypertension, diabetes, and he wasn't pregnant. So you can see that scoring system, he had very good prognosis, and that's why we didn't spend much time with him. But it's important to bear this in mind when you see a patient with him. So ocular complications, usually the esophageal keratopathy with lubricant, you can do tastography, you can have to treat. So be sent to a corneal specialist if you see that problem. Let's discuss this brief syndrome. It's like herpes zoster ophthalmicus, something like that, reactivation of varicella, but this one is the articles, the same principle. So any part of the nerve can be affected because it's a retrograde affectation. So it can affect the vision nerve proper, it can affect the caudal tympani, it can affect the greater perceptual. So these are the vesicles you see in the ear. Moderate to severe pain, very overt clinical sign, they're just very few, okay? Okay, yeah, it's right. It's right, Bell's palsy, yeah. So within a few days, they develop into a facial nerve palsy, but they have this DVT, definite vertigo, and tinnitus. Vesicles will be visible during this period, so it can affect the anterior to tongue. So the facial nerve tend to be more severe than the palsy in this patient that have Ramsay-Hunt Syndrome. So diagnosis is clinical. Biology studies can be requested if necessary, but add very little because it's already diagnosed clinically. Here, if you want to start a cycle of it, and it's been proven to help them. Unfortunately, only 75% of cases will resolve with these treatments. So you can have chronic tinnitus and vestibular dysfunction. Okay, so in summary, facial nerve palsy is weakness or paralysis of the muscles of the face, the most common cause of which is Bell's palsy, but it's idiopathic. But you have to really do all you can to find out if it's idiopathic or not. Forehead sparing can be used to distinguish between upper motor neuron lesion and lower motor neuron lesion. Most cases of Bell's palsy resolve spontaneously. Management is by conservative, either steroids or antivirals. So Ramsay-Hunt Syndrome is a herpes zoster articles and has worse outcome than normal Bell's palsy. And if you have recurrent Bell's palsy, you want to, send them for more imaging. So in conclusion, if you have a cranial nerve palsy, whether it's 7th or 3rd or 4th or 6th, you want to ask yourself, is it the first episode? Is it isolated? On which side? So we've already talked about it, but it's important that I end with this because this is the main reason why I chose Bell's palsy. Because Bell's palsy is very simple, but I want to use it to touch base with other cranial nerves. And this is a very good management approach to make sure you don't miss anything. So in summary, 5 key things we should pay attention in people who have Bell's palsy for ophthalmology basis: lack of ophthalmos, if they have good Bell's phenomenon, the corneal sensation, the tear film is very important. You want to assess clear film everybody has Bell's palsy in both eyes. I want to check the cornea. if his integrity is fine, the structure, you might need a tarsography. So thank you for listening. That's the end of the. So if you have any questions, it's fine.
Thank you very much, Dr. Nwachukwu, for the beautiful and elaborate presentation and making neuro-ophthalmology more enjoyable for all of us. Thank you very much. So in the chats, we have a question here. They want to know if it's important to state if it was a right or a left Bell's palsy in the diagnosis, because it wasn't stated in the assessment of the case that was presented.
Yeah, it was an oversight. It's a right Bell's palsy. So you can also say right idiopathic cranial 7 palsy, lower motor neuron type. Yeah, but this case was a right. Yeah, I missed it. Sorry.
Okay, thank you very much. Do we have any other questions, comments, clarifications for Dr. Nwachukwu? Hello, can everyone hear me?
Yes, we can. It was an interesting session indeed. Thank you so much, Dr. Nwachukwu.
Yeah, my chief, I lawyer. I mean, yeah, I'm happy to be here anytime. Thank you for listening.
Hello, thank you so much, Dr. Nwachukwu. Please, I think I may have missed it when you were talking about the medication. I said everybody gets 25 milligrams. Is that for steroids?
Yeah, prednisolone. You know, it's not everybody that gets it. So the problem that they have is that it's only when, I don't know what happens in Nigeria, honestly. I don't know how the public physicians manage it. But I think that what they do here is that they try to have everybody see them before you start the steroids. So they don't want to start steroids and the person doesn't have Bell's palsy because they're not sure. So they do the imaging and in EIE to ensure there's no stroke. Then they check to ENT. ENT will see them. If ENT finishes seeing them, then there's no ear problems, it's otitis media or whatever. Then they now send to ophthalmology to be sure that there's nothing bad in the eye. We now send back to GP. GP will now start the steroids. So the guideline is to give 25 milligrams of steroids, you know, but people really don't believe that it helps. There's a lot of controversy. So, I mean, and by that stage, it might be recovering, but that dose was steroid. It was prednisolone, yes.
Okay, thanks. Any idea how long they give it, when they give?
It's 3 weeks, yes, I heard you. It's 3 weeks. So, you know, look at the prognostic factors, right? They believe that it should resolve before 3 weeks. So the GP will give them weekly and monitor them weekly. And by the end of the 3rd week, they believe it should improve 100% or maybe 90%. If it doesn't improve, then they send him back to the ophthalmologist or ENT because at that stage, it has passed GP care. So everybody usually resolves by 3 weeks. That is a cutoff line. So they take the drugs weekly, then they check do their GP weekly. Then if they don't recover after the 3rd visit to their GP, then they send them back to the ENT. So if you look at it here, I guess, let me just read it.
Okay, thank you very much.
You're welcome, man. Yeah, so it's 3 weeks. The recovery is expected by 3 weeks. So everything is 3 weeks, yeah.
Okay, thank you very much. Do we have any other questions or comments? Any other questions or comments? Okay, thank you very much, Dr. Nwachukwu, for the presentation. I particularly enjoyed the way you described the facial nerve. Makes it quite easy to remember its functions. Thank you very much for that. Then also, I think a family history of Bell's palsy is also important, although not common. So quite rarely, there could also be a genetic predisposition to Bell's palsy. So when clerking wants to take a history of similar symptoms in the past in other family members too. Hello, Dr. Nwachukwu.
Yes, I was muting myself.
Okay.
So yeah, I agree with you. It's possible that but honestly, I've never read it anywhere, but I agree that it's always good to add family history. And I appreciate that you added that bit. I didn't know that, but add it to my knowledge base. Thank you for that addition. I didn't know that before now.
Okay, thank you. So do we have any other questions or comments? We're coming to the end of the presentation now. So do you have any questions or comments for Dr. Nwachukwu? Let's start from his wealth of knowledge before the end of this presentation.
Which one is wealth of knowledge again? Please, man.
Yes, now. Okay, someone is raising up her hand. Dr.
His wealth of knowledge and expertise.
Which one? Calm down
Yes.
now. Go now, cool down. Which expertise? Well, I used to tell people that I'm just an SR. I don't know why people keep saying this expertise. We are just SRs. We will collect the qualification.
SR neuro-ophthalmologist, but we know now.
Cool down now. I agree to now. Thank you for the opportunity. I'm always happy to share small knowledge. You know, it's called knowledge sharing, and I appreciate it. A lot of people have stuff here. But you guys chose me to present. I appreciate it. Thank you.
Thank you.
Morning. Thank you
Dr.
for the
Rabiu,
presentation.
you have a question?
Yeah, go on. So
I wanted to ask, how can we access the recordings, please, if you want to listen again?
Okay, it's our guys that will tell you that one at the YOF committee. I don't have
okay.
They will,
we'll make it available, Doctor.
Okay, thank you.
Okay, so thank you very much, everyone, for the time. Thank you, particularly to Dr. Nwachukwu for the presentation and to everyone for making out time to attend this. Our YOF chairman, I can see is in the meeting. Hello, sir. Dr. Eze. Is it still with us?
Good any comment to make for the moderator. So appreciate.
So, sir, we can't hear you.
Wow. Say thank you.
It's breaking.
I did not want, but thank you for the invitation. Thank you for the moderator. Happy all.